Sarah is really a wonderful clinician and teacher. She's one of the key people in our immunocompromised host division that takes care of patients with infections with cancer and transplants. She's been doing research, and she is one of our really lead teachers in the division. And she'll be talking about infection in the immunocompromised host. So I'll turn this over to Sarah.
Thank you so much for that introduction. I'll go ahead and get started. And welcome to everyone. So first, my disclosures. I have research funding from Merck and iCuris. So just to give you an overview of what I'm going to talk about today, it's a relatively big topic. So here's my approach. I'm going to give you an introduction, and then I'm going to review some of the basic principles of infection in the immunocompromised host. And then we're going to move on and talk about drug-induced immunodeficiency, which is a huge area. And I'm going to focus on 4 specific types of drugs that can suppress the immune system. Then we'll cover asplenia briefly, and then lastly, transplant. So first, introduction and basic principles. The immunocompromised host is susceptible to opportunistic infections and community-acquired infections. So sort of two sides to what you expect to see in them. An important detail to remember is that infection can result from exposure to a relatively low number of organisms. So it doesn't really take that much to get these patients infected or sick. So what this can mean, practically speaking, is that sometimes these are the first types of patients to show up in your practice who have something that is developing in the community. So, pre-COVID times, my example was always something like influenza. They can be the first, an RA patient on an immunosuppressant can be like maybe the first person to show up in your office with influenza. Or, for example, if there's like a norovirus outbreak from a local community restaurant, they might be the first person to show up that actually has severe enough symptoms to come in to be seen. So another really key point with these patients is that the inflammatory response to infection is suppressed. So what this means is that they can have attenuated signs and symptoms of infection. So not only do abscesses on the skin look less angry, but might be quite advanced, I think the most important thing that's attenuated is fever. So these patients sometimes really don't or can't mount a very impressive fever. This is particularly true of patients on steroids, as we all know. And so, for example, if a kidney transplant patient calls you and says, I really don't feel quite right, I have a fever to 100.2 and I'm under the weather, you really need to take that patient seriously. I always use this example because it's reminiscent of a case I saw in July several years ago where kidney transplant did that exact thing and was given advice by a new trainee to stay home and call with a real fever, meaning 101. Which she diligently waited. And when she came in, she had Staph aureus bacteremia that was high grade. So presumably the low grade fever was telling us that, and we didn't need to wait for the high grade fever. And then lastly, the immunocompromised host with infection typically has a really high burden of organisms once infection is established. So it doesn't take much of an exposure to get them sick. But then once they do have the pathogen, they don't have normal host defenses, so they don't handle it the way the rest of us, who aren't immunocompromised might. And then in that scenario, it means they can sort of be teeming with organisms. Now, if it's something that's not communicable, that's good to know, but doesn't have many implications. If it's something communicable, that's kind of a big deal, particularly when it's something, that can have effect on pregnancy and this sort of thing. The classic example of this is varicella zoster. So for example, at my institution, an immunocompromised patient, for example, a patient with on active chemotherapy for, let's say, leukemia, shows up with dermatomal zoster, that patient would be put on the precautions that we would normally reserve in a normal host for disseminated zoster. And that's because they can have a higher burden of the varicella virus, which makes us concerned that they can transmit it, in a respiratory fashion. So you just have to think about what it means if the person has a higher burden of organisms, if the infection is transmissible. So the next thing I want to talk about are some of the basic principles of infection in these patients. In 1998, Jay Fishman and Bob Rubin at Mass General wrote this very nice review article for the New England Journal that laid out the basic principles of infection in transplant patients. But when I think about the points that they make and how medicine has evolved, their concepts really broadly apply to people who are immunocompromised for other reasons now. Because, in the last 20 plus years, we've really developed a lot of drugs that are immunomodulatory. So I think it's worth reviewing their basic principles because they really apply to this whole patient population. So the first sort of cornerstone of their argument is that you need to consider the net state of immunosuppression of the patient that you're seeing. So the obvious part of that is thinking about the dose and duration of immunosuppressive medications. How much prednisone, how long, how much chemo, how long have they been getting chemo, that sort of thing. But the other thing that you need to consider is, do they have mechanical factors that make them more vulnerable to infection? This sounds kind of unfamiliar at first when you mention it this way, but I'll give you a few examples. So number one, if a patient is on hemodialysis, and they're being dialyzed through a tunneled catheter, that tunneled catheter provides access to the bloodstream. It also is a mechanical thing that makes that patient more vulnerable to both a tunnel line infection, but also a bloodstream infection. Another mechanical factor I think about a lot in my practice at the Dana-Farber Cancer Institute is people who've had procedures that affect their lymph nodes. So for example, a lymphadenectomy in the axilla or the groin, or patients who've had a lumpectomy and radiation to the breast. Those patients will be vulnerable to sort of inadequate or altered lymphatic drainage in that area. And that can really predispose them to recurrent cellulitis. So you really have to think about what physical things are making this person vulnerable. And then the last thing is, are there any infections that are making these patients more vulnerable? So the classic example of an infection that makes someone vulnerable to other infections is HIV. Simple example, but it's not that common. In the transplant world, it turns out having an active CMV infection will make you more vulnerable to other infections. But even in sort of general non-immunocompromised hosts, there are certain infections that will bring on other infections. So influenza is one that we are all probably familiar with from medical school that can sort of lead to superinfection with either Staph aureus or strep pneumo. There's increasing data that also aspergillosis can come on the heels of influenza. And I would say for all respiratory viruses in immunocompromised hosts, you have to be really careful to watch for the second act, which is usually a bacterial superinfection or pneumonia. So the other cornerstone of the argument about the basic principles of transplant infectious diseases is understanding epidemiologic exposures. So obviously this incorporates new exposures. Did the patient eat at the restaurant where there's a norovirus outbreak associated with the food? That would be a new exposure. Or, did the patient have contact with somebody with COVID? Those are new exposures, and we're pretty good at thinking about those. What we are less familiar with thinking about are remote exposures that have the possibility of reactivation. The classic example of this is tuberculosis, but there are many other examples. Endemic mycoses like histoplasmosis and coccidiomycosis, you can have grown up in Arizona and then be on the East Coast living and immunocompromised for some reason, and you have to think about whether coccidioides could reactivate if you were exposed when you were a child, for example. Other sort of thinking more broadly with very strong immunosuppressants, we really need to think about all the herpes viruses. Did this person actually have zoster, or chicken pox when they were a child, or were they vaccinated, which makes us worry a little less. Has this person had hepatitis? Specifically, hepatitis B is a virus that even if you clear it, you can reactivate it later. So all of those kinds of exposures are things we need to think about with very immunocompromised patients. So let's move on and talk about drug-induced immunosuppression. So I promise this is my last sort of background slide, and then we'll get into some specifics. When I think about drug-induced immunosuppression, there are sort of three key things: the mechanism of the drug, why the drug is being given, and the dose and duration. There are a huge number of immunosuppressants approved to treat malignant and autoimmune disorders, and it's constantly expanding. As you know, it's hard to keep up with the MABs, which are drugs that are monoclonal antibodies, or the IBs, which are small targeted molecules. There's a lot now. You can't, look at any medical publication without seeing ads for these. So knowing the mechanism of the immunosuppressive agent is really going to be the key to predicting the host susceptibility. The sort of most elegant example of this I can think of is a drug called eculizumab, which is a C5 complement inhibitor. It's approved for the treatment of myasthenia gravis and atypical hemolytic uremic syndrome. And what it effectively does is it blocks your terminal complement chain. Now, if you think back to medical school, what happened to people with congenital terminal complement deficiencies? Well, most of us probably remember those people have problems with meningococcus. Specifically, they are much more risk prone to that. And it turns out if you are treated with eculizumab, the risk is similar. You are much more prone to getting meningococcal infection. And so by knowing the mechanism, you can predict what's going to happen, and you can protect these patients by vaccinating them. So the indication for which an agent is given is also going to be important when you're considering the impact on host defenses and what kind of host the person is. For example, rituximab is approved for the treatment of rheumatoid arthritis, but it's also approved for the treatment of lymphoma. So lymphoma patients are quite different at baseline than a patient with rheumatoid arthritis, because lymphoma patients may already have some degree of immunocompromise. They may have already gotten chemotherapy. They're going to get other agents along with their rituximab. So you have to think about the context, the host. And then lastly, you want to know the dose and duration over which the agent is given and how long the agent remains active, because that's going to impact your vulnerability. Some biological agents, monoclonal antibodies, are active for 6 months or more. So rituximab, for example, in sort of my simplistic terms, once somebody gets a dose, I sort of start the clock and say 6 months, they are vulnerable after that. Whereas eculizumab, the drug I was just talking about, has a shorter half-life and a shorter impact on the immune system. So after a few months from the last dose of eculizumab, the person's meningococcal risk will sort of fall back down to normal. So this is by no means an exhaustive list of immunosuppressive drugs out there. It's just to give you a flavor of, what has to go through your head when you're thinking about the immunocompromised host. There are several classes of drugs. So on the left-hand side are some of the older ones. So corticosteroids, antimetabolites like methotrexate, azathioprine that we use in autoimmune disorders, T lymphocyte active agents like tacrolimus and cyclosporin that are typically used in transplant. And then the bottom half of the left column are much newer agents. So these are targeted agents. These are small molecules. They're not monoclonal antibodies, but they're biologically active. They interfere with biological pathways important for immune system function. So there's Janus kinase inhibitors, which includes tofacitinib, which is a very popular drug right now. There's proteasome inhibitors, which we use often for multiple myeloma. And then on the right-hand column, I've listed a variety of classes of monoclonal antibodies, including tumor necrosis factor alpha inhibitors, which many of us are familiar with, CD20 antibodies, the IL-6 receptor antibodies, which many people became familiar with because it was tossed around as potential treatment for COVID-19. We are still awaiting formal data on that. IL-1 inhibitor anakinra, which is used for rheumatoid arthritis, was also kicked around for management of immune reactions to COVID-19, and then T-cell co-stimulation inhibitors. For the purposes of this talk, though, I really just want to focus on the ones that I think are most common and important for general practice. Steroids are all around us, so we'll talk about that. We're going to talk about Janus kinase inhibitors because I really think that their use is growing quite a bit, particularly in rheumatology. We'll talk about TNF-alpha inhibitors and CD20 antibodies. So steroids, the acute effect of steroids on host defenses includes neutrophil demargination, which causes the high white cell count, and reduced chemotaxis. Lymphopenia and depletion of T lymphocytes also happens. These effects are why they're so useful. A less useful complication or effect of steroids is that it causes skin weakening and poor wound healing when you've been on them for a while. And this is something we intuitively see, right? We see this in our patients on steroids. You can look at their arms and see if they have like a minor scratch, it really does not heal well. So what about steroids and infection? In general, steroids increase the risk for infection. You did not need to wake up if you're on the West Coast to hear me say this, to know this is true. So I promise I have more data behind this. In a controlled study, in many controlled studies, typically the impact is greater on the risk of severe or hospitalized infections relative to sort of outpatient management. In a meta-analysis of 71 controlled trials that looked at steroids versus non-steroid, non-immunosuppressive therapy, steroid recipients had significantly higher rates of infection, as you can see, and more than twice the rate of lethal infection. And this meta-analysis included studies that were looking at steroids used for all types of indications, GI, pulmonary, renal, etc. So you might be thinking, like, why is she talking about this meta-analysis? It's from 1989, if you're reading the bottom of my slides. The reason that I love this meta-analysis is because of this graph right here. So I'll go into it in detail. On the x-axis is duration of steroids in days, and on the y-axis is the dose of steroids in prednisone milligrams equivalent per day. The studies that found no difference between steroids and the alternative are the open circles. And then the studies that found that steroids increase the risk of infection are the filled in squares. So what you notice is that the filled in squares fall along a diagonal line. And if you look at that diagonal line, what it suggests is that in the studies where the doses of steroids are relatively high, for example, 100 milligrams of prednisone per day, you didn't have to be on steroids for that long for your infection risk to increase. Whereas if you were on a relatively low dose of steroids, like a little bit above 10 milligrams per day, you had to be on them for a few years before they really saw a statistically significant increase in your risk. This particular study didn't show an increase in risk for infection at 10 milligrams below 10 milligrams of prednisone per day. That being said, since then, since it's a very old study, large database studies looking at RA, IBD, and psoriasis have found that there's a difference in infection risk between less than 5 milligrams of prednisone per day, 5 to 10 milligrams of prednisone per day, and then greater than 10 milligrams. And it increases sequentially your risk based on the steroid dose. Also, the dose-dependent risk of less than 10 milligrams of prednisone per day has been shown in other observational studies. So even baby doses of steroids probably matter. So what are the specific infections? We already covered that you can get community-acquired infections, but what are the opportunists? It runs the gamut if you look. It includes things like listeria, fungal infections, viral infections like zoster, latent tuberculosis reactivation, strongyloides hyperinfection, and most importantly, pneumocystis jirovecii pneumonia, or PCP. I really want to dive in on this one because this is preventable and an important complication. Steroids are really the major risk factor for PCP. In a study of 116 non-HIV patients, 91% were on steroids. And similarly, this has also been demonstrated in a study of non-HIV cancer patients. While PCP in non-HIV patients is a rare event, it's associated with a really significant mortality that I think we sometimes forget about. The mortality rate among 114 non-HIV cancer patients was 49% in one study. In a totally different study, different patients, different part of the country, the cancer one was in New York. This one I'm talking about now, among 223 patients with connective tissue disease, was done in the Kaiser system in California, demonstrated that the in-hospital mortality from PCP and connective tissue patients was 45.7%. Those are very similar statistics in two totally different studies. It shows that if you don't catch somebody, if you don't prevent PCP in someone on steroids and they get it, their mortality chance is pretty high, unfortunately. So this is why we need to think about it. The PCP risk does depend on the steroid dose and duration. So among 105 non-HIV patients with PCP, the median dose was 30 milligrams of prednisone per day, and the median duration was 12 weeks. The PCP risk, though, may not be uniform among all patient types. In general, if you look in the rheumatology literature, the risk in lupus, temporal arteritis, rheumatologic disease is typically linked to what they refer to as high-dose steroids, so typically 30 to 50 milligrams of prednisone per day. The risk may be especially high in people with metastatic cancer on steroids, probably because they're getting dexamethasone, for example, particularly with brain metastases. And sometimes that one can fly under the radar because the steroid equivalent dose is about 6 to 7 milligrams of prednisone per 1 milligram of dexamethasone. So sometimes it's underappreciated how high the dose is. The PCP risk is also elevated, but it occurs less frequently in inflammatory bowel disease. There's a very nice study from Mayo Clinic that demonstrates this. So at what dose and duration of steroids should prophylaxis start? That's what you want to know. Unfortunately, there is no study that directly assesses this. So ID providers do our best. We extrapolate from the available data. The study above is one of the ones we look at. And we typically sort of say, in a little bit of a hand-wavy fashion, start prophylaxis after about 3 to 4 weeks of 20 to 30 milligrams of prednisone per day. So let's move on and do a case. Get ready to vote. This is a 55-year-old woman with RA who has 3 days of a cough and dyspnea. She had a fever as high as 100.9 for 2 days. Her RA was diagnosed 15 years ago, and she's on infliximab and methotrexate. She lives with her husband in rural Massachusetts, works remotely in publishing, and has been fully isolating at home, including having groceries delivered. But she does walk outside every day because she lives in a pretty isolated place. She walks around a lake that she has. And I'll tell you that COVID-19 transmission is relatively low in Massachusetts now. You can pretend it's now. Her on exam, she's febrile and tachycardic, and she requires a decent amount of oxygen. She has crackles in her lungs. She has a leukocytosis with a left shift. Her chest x-ray shows dense infiltrates in the right upper lobe and left lower lobe, so it's multifocal. And this is a representative picture where you can see the infiltrate in her right lung. So, which is the most likely cause of her pneumonia? Please get ready to vote. A, Legionella pneumophilia, B, COVID-19, C, Aspergillus fumigatus, D, influenza, E, Mycobacterium tuberculosis. So go ahead and get ready to vote. And I'm going to give a little hint, which is that, as I said, COVID-19 transmission is really quite low in Massachusetts right now. Our testing rate is hovering just below 2% when I last looked. So 2% of all tests are positive, just to give you a hint. Okay, I'm going to give you another 30 seconds, and then we're going to move on. Okay. What I love about this is that I'm seeing a big split between everybody. Okay. I'm cutting you off. So the answer here is Legionella, and I'll tell you, this is a little bit of a fictionalized case, but that is an actual picture from Legionella. I like throwing this in here because it's kind of a side note, but I think many people hear Legionella and they think atypical pneumonia, and it's going to like sort of have this bilateral ground glassy looking thing. Not the case. Legionella causes very dense, nasty infiltrates and makes people extremely ill. COVID-19 has changed things, and her chest CT scan is not really consistent with COVID-19. And I was sort of trying to give you hints that probably this wasn't COVID-19 because our transmission in Massachusetts is really quite low. Certainly in someone like this, you would absolutely test them. So if she walked into the ER now, we would definitely be ruling it out. Aspergillus is less likely in her. The tempo doesn't fit. The imaging isn't quite right for influenza. And then the tempo is not really right for tuberculosis either. So moving on, TNF-alpha is an inflammatory cytokine produced by macrophages. It's important for the control of infection with intracellular organisms and for granuloma formation. There's 5 FDA-approved drugs that inhibit TNF-alpha. Monoclonal antibodies that bind TNF-alpha include infliximab, adalimumab, and golimumab. And then certolizumab is a pegylated portion of a monoclonal antibody that binds TNF-alpha. TNF-alpha receptor that binds soluble TNF-alpha is etanercept. The reason I go through this is mostly to tell you that etanercept is different. It's not a monoclonal antibody. The name doesn't end in mab. And so some of the infectious diseases complications are a little different. So there's also this whole host of drugs now called biosimilars that are biological products that are very similar to approved agents. They have improved cost and availability, though. So just know that in the last 5 years, the FDA has approved many biosimilars for infliximab, etanercept, or adalimumab. So if you're unfamiliar with the name, you should Google it. Honestly, that's how I do it, or do your Bing search, whichever search you prefer, to figure out which drug it's similar to if you're wondering. So several studies and registries have assessed if TNF-alpha inhibitors increase overall risk of infection. And many studies have looked at bacterial infection in particular, and the results have been mixed. A meta-analysis that included 9 trials assessed the infection risk in RA patients treated with infliximab or adalimumab versus non-TNF-alpha therapy. The non-TNF-alpha therapy was placebo in this case in the studies. The pooled odds ratio for serious infection was 2, so the infection risk was increased. And most infections in the study were bacterial. But this study is limited. It's not very real world because most patients with RA were not going to put on a placebo. So comparing a TNF-alpha inhibitor to placebo, yes, your infection risk is increased if you're getting the immunosuppressant versus a placebo. But what's a real world comparison? Well, this was also assessed in a slightly more recent study that included patients on infliximab, etanercept, or adalimumab for autoimmune disorders. It was a large propensity score analysis that included 16,000 patient records. And there was no difference in serious infection between those treated with TNF-alpha inhibitors and real world comparators, whatever the physician chose. And so the one thing to know about the study is that there was this very slight increased risk in the 10,000 RA patients who were on infliximab versus all other comparators, including the other TNF-alpha inhibitors. So maybe a slight infection increase with that particular agent. So what about TNF-alpha inhibitors and opportunistic infections? They've been associated with several different opportunistic infections. Tuberculosis is the most common internationally, but that is not a very common complication in the US. In a large US database that looked at 33,000 new TNF-alpha users, pneumocystis was actually the most common opportunistic infection, followed by nocardia and then tuberculosis. And then you can see there's a whole host of other infections that include the endemic mycoses like histoplasmosis, non-tuberculous mycobacteria, salmonella, listeria, legionella, etc. So in a French registry study of infliximab, adalimumab, and etanercept, the incidence of opportunistic infection was low, but the severity of illness was very high. The median time to opportunistic infection was 16 months, and the OI risk was significantly higher in patients treated with infliximab versus etanercept. In a US database of the same TNF-alpha inhibitors, the incidence of non-viral OIs was also relatively low, but was significantly higher than patients treated with non-biological therapy. And so what both studies showed that I really took to heart from these two studies was that the OI risk is much higher in people on TNF-alpha inhibitors who are concurrently on steroids. Those are the people that you really need to watch out for. Those are the people where I would worry about PCP, even if the prednisone dose is 15 milligrams per day, because they're on 2 different agents. So there's something special about being on a TNF-alpha inhibitor and prednisone that can make your risk much higher for an opportunist. So what about tuberculosis and TNF-alpha inhibitors? This was first looked at a long time ago. In 2001, there was a study that looked at all of the cases of TB that had been reported to the FDA in association with infliximab since its licensing in 1998. There were 70 cases, and more than half of them were extrapulmonary TB. The median time to TB was 12 weeks. The increased risk has been demonstrated in many large database studies from Europe and the US, but these studies have shown some subtle differences between TNF-alpha inhibitors. And this is where etanercept versus the monoclonal antibodies matters. The TB risk after infliximab is comparable to adalimumab, both monoclonal antibodies, but higher than after etanercept. And then TB develops later. If you're on etanercept, you expect it to show up at about 12 months, as opposed to about 3 months with monoclonal antibodies. With any of these drugs, though, before you give them, you need to screen people with either a PPD or an interferon gamma release assay. And I know we have a recorded lecture that addresses tuberculosis and talks about these tests. So let's move on and do my next case. So get ready to vote again. This is a 58-year-old woman diagnosed with diffuse large B-cell lymphoma after she presents with fevers, night sweats, weight loss, and left neck swelling for several weeks. Her medical history is notable for an episode of hepatitis requiring a hospital stay after she was stuck by a needle when she was training to be a phlebotomist about 35 years ago. Plans are made to initiate R-CHOP chemotherapy. Physical exam is notable for a thin woman with a very enlarged area of lymph nodes in her left neck. Labs are notable for normal BUN, creatinine, AST, ALT, and bilirubin. Her serologies are as follows. Hepatitis B surface antibody is 27 international units per liter. Hepatitis B core IgG is positive. Hepatitis B surface antigen is negative. Hepatitis B PCR is negative. Hepatitis C virus antibody is positive. Hepatitis C virus PCR is negative, and HIV screening is negative. What is the best management for her previous hepatitis exposure? A, monitor hepatitis C PCR and surface antibody every 2 weeks while she's on chemo. B, start prophylactic low-dose ribavirin and lamivudine to continue for a year. C, start prophylactic entecavir to continue 12 months after chemotherapy. D, no special care is indicated since both hepatitis B and C are old infections that have resolved. So go ahead and ring in. I'll give you a few more minutes. Okay, last 5 seconds, and then we're gonna move on. Okay. Oh. There we go. So the answer is C. It looked to me like there was sort of a smattering between C and D. So let's talk a little bit more. So number one, first thing to get out of the way, hepatitis B is a DNA virus. Hepatitis C is an RNA virus. Hepatitis C, once it's cleared, if you've had it, but you've taken your medication course or you naturally cleared it, if it's gone, it's gone. So it doesn't reactivate with something like rituximab or steroids. So that's why A is wrong. And that's also why B is wrong, because it has this ribavirin in it. So then that narrows us down to C and D. What I will tell you is that hepatitis B can reactivate even if you've sort of cleared it. After you give something like rituximab, and we'll talk more about why you would choose prophylaxis or at least monitoring, but there is special care indicated. So CD20 antibodies. Rituximab is a monoclonal antibody to CD20, which is a B lymphocyte marker. Immunologically, the effect is to deplete B lymphocytes. Functionally, this means you have an inability to mount an antibody response to new or recall antigens, so it really affects your ability to respond to vaccines after you've received rituximab. It's FDA approved for the treatment of some lymphomas, CLL, or rheumatoid arthritis. Ofatumumab and obinutuzumab are newer anti-CD20 antibodies that are exclusively used in hematologic malignancies, so you probably won't see them as often. And then there's this newest drug, which I think you probably will see used, which is called ocrelizumab. And that's approved for the treatment of multiple sclerosis since 2017. And it also likely has the same infectious complications as the other 3 drugs in this family. So pre-marketing trials showed no increase in infection risk in RA or cancer patients getting rituximab versus non-rituximab regimens. And ocrelizumab trials have shown no increased risk for infection in multiple sclerosis patients. But with clinical use, there have been a lot of reports of opportunistic infections. It includes things like PCP and PML due to JC virus, but also things like CMV reactivation, pure red cell aplasia due to parvovirus, and enterovirus encephalitis. But the large caveat to this is that you have to think about who these patients are and who they're looking at. And so case reports can be unreliable in this patient population because some of these patients have been on multiple immunosuppressants or are concurrently on multiple immunosuppressants. That means that what they're reporting is not directly linked to rituximab or an anti-CD20 antibody. Rituximab and sort of by default, we think of the other anti-CD20 antibodies as being associated definitively with hepatitis B reactivation, and then an increased severity of babesiosis in people who are exposed. I'm going to talk about hepatitis B because I think that's the most important. So in order to have hepatitis B reactivation, first you have to be exposed to hepatitis B. That can happen perinatally, percutaneously, or sexually. You'll go on to develop an acute hepatitis B infection, which means you become surface antigen positive and your DNA becomes positive. So if you're an adult when you get it, about 90% of the time, or maybe more, you will resolve, and I say that in air quotes, your hepatitis B infection, meaning you become surface antibody positive, your DNA becomes undetectable, and you develop this core IgG that is a marker that you had natural infection. That being said, once you've had natural infection, you will have a small reservoir of retained hepatitis B DNA and hepatocytes, and that's the source for reactivation. Some people will go on to develop chronic hepatitis B, though, about less than 10% if you're an adult, which by definition means you're surface antigen positive for 6 months. You still have detectable DNA, and you also have this core IgG as a marker of natural infection. Within chronic infection, there's a few different disease states you can be in. Chronic active infection, where your DNA is high, your LFTs can be high or low, it turns out in this category, or you can be what's called an inactive carrier. So these people make this E antibody to one of the hepatitis B antigens. And in that sense, they will get some control over their hepatitis B DNA. So they'll have a low DNA, and usually they have normal LFTs. So these people fly under the radar sometimes. So it's these people and these people, when you give rituximab, can reactivate, meaning surface antigen becomes positive if you're in this category, or E antigen becomes positive if you're in this category. Your DNA becomes very, very high, and you develop abnormal LFTs. So fulminant hepatic failure and death have been reported with reactivation with rituximab and some of the other CD20 antibodies, as you can see. The risk of reactivation is higher in people who are surface antigen positive, these chronic carriers, than in patients with resolved hepatitis B. So how do you prevent this? That's what we want to do, right? So all patients getting CD20 therapy, and for that matter, TNF-alpha inhibitor therapy or high-dose steroid therapy, should be screened for hepatitis B before you give the therapy. Antiviral prophylaxis is typically going to be given to inactive carriers, and you want to pick an agent with a high barrier to resistance. So that's something like tenofovir or entecavir. Lamivudine I had on my first slide, that has a low barrier to resistance, so it's not a good choice. So what about the core antibody positive patients? Guidelines advocate for prophylaxis in these patients, but recent studies have shown that you could monitor them every few months with virus load and surface antigen. So it kind of depends upon where you are in your practice and how well you can monitor the patient. One note I will make, TNF-alpha inhibitor therapy appears to have very low risk of causing reactivation in the core antibody surface antigen negative population. So you would not necessarily need to take a prophylactic approach in those patients. So let's move on and talk briefly about JAK inhibitors. Janus kinases are a group of 4 kinases that bind to cytokine receptors that activate a complex set of signals that lead to inflammation and immune activation. They have a very complicated impact on the immune system that varies depending upon the dose and which JAK is targeted. There's currently 4 FDA-approved JAK inhibitors, and there's a lot in development right now. People are very excited about this drug. The one you're probably most familiar with is tofacitinib. It's approved for rheumatoid arthritis, UC, and psoriatic arthritis. And most of the studies that we know about this family of drugs are from tofacitinib. Ruxolitinib probably flies under the radar because it's just approved for myelofibrosis and polycythemia vera. So unless you practice at a cancer center, you may be less familiar. Baricitinib was the 3rd one approved. It was approved in 2018 for RA patients not responding to or intolerant of TNF-alpha inhibitors. And then the most recent one is this drug called upadacitinib. And that one just inhibits JAK1, which is a little bit different than the others. And it's considered a 2nd generation, so it should have fewer side effects. But we'll talk about how it has a similar complication. So it was just approved in 2019 for RA patients who don't respond to methotrexate. So the main problem with JAK inhibitors is that they can cause zoster. Clinical trials and meta-analyses of these 4 agents have largely shown no increased risk for serious infection otherwise. And so the risk is consistent for zoster across all patient types. And this is one of my favorite studies of this. It was a study of over 70,000 RA patients on biological or targeted therapy. And they looked at what type of biological or targeted therapy they were on, and that's listed in this column here. It included all of the TNF-alpha inhibitors right here, and then it included rituximab and tocilizumab, and then tofacitinib's right here. And what you can see is that all of them have similar zoster risks, which is similar to the comparator drug, which was abatacept, except for tocilizumab, which is way out here with this increased risk. So definitively increased risk. The severity of zoster, though, is not increased. And so I think we all wonder if the key is going to be vaccination here. We need more studies of the new subunit vaccine with this drug to know that. But hopefully this is something we can control and predict. So let's talk briefly about asplenia. Immunologically, the spleen plays an important role in filtering blood. And as you probably all know, patients are at risk for overwhelming bacterial due to encapsulated organisms, so strep pneumo, Haemophilus influenza, and Neisseria meningitidis. A recent study of severe sepsis and asplenia showed that strep pneumo caused 42% of infections. Most of them were bacteremia or meningitis, and it was more than any other pathogen. Interestingly, this study showed that Haemophilus influenza and Neisseria meningitidis were not seen in any of the other cases of sepsis. So it goes to show strep pneumo is by far the most important in this category. Progression of infection can be rapid with a high mortality, and the risk may vary by the reason and time since splenectomy. So the longer since the splenectomy, we think of the risk as being less. The other thing to know is that if you know that you have a risk for bacterial infection, that can reduce your risk for having overwhelming sepsis. So in one study of patients who, among the 79 patients who had poor knowledge of their risk, almost 17% had suffered from overwhelming infection, whereas fewer than 2% among 142 patients with good knowledge had had this complication. So vaccination is really the key for these three pathogens. The timing, so typically we would vaccinate 2 weeks before the splenectomy in planned cases and within a week or two after in unplanned cases. And what I would say is that in unplanned cases, the most important thing is to vaccinate them before they leave the hospital. Don't miss the opportunity by dickering over the exact right timing. Just get the vaccines in before they leave so that you don't miss the opportunity if they're lost to follow-up. So vaccination algorithms, I'll just remind you, strep pneumo now has 2 different vaccines that are recommended, the polysaccharide vaccine and the conjugate. If somebody's never had any pneumococcal vaccines and they get a splenectomy, you start with the conjugate vaccine and then you would give the polysaccharide at least 8 weeks later. And then Neisseria meningitidis, I'll remind you, these are patients who should get both. So both the old conjugate ACWY vaccine and the new meningococcus type B vaccine series. So 2 other pathogens we worry about in asplenic patients. One is Capna cytophaga caenomorsis, which colonizes dog mouths. It can cause sepsis and an infection that looks like meningococcus. It's usually susceptible to beta-lactam, beta-lactamases, so things like ampicillin sulbactam. And asplenic patients just need to be educated about this. They need to carefully clean animal bites, and they should call if they get an animal bite, because typically people would give a short course of something like amoxicillin clavulanate to prevent an infection from this pathogen. And then babesiosis. So this is a tick-borne malaria-like parasitic infection endemic in the northeastern US, Wisconsin, and Minnesota, causes fevers, malaise, anemia, and thrombocytopenia. The severity of babesiosis is increased and the parasite burden is higher in asplenic patients. So they may require prolonged or repeated courses of treatment. And then lastly, with asplenia, how do you manage fever? It turns out many people have poor knowledge of their infection risks. So your first job is to educate, and then your next job is to give them a prescription for an antibiotic that's active against strep pneumo and Haemophilus influenza. So this is something like levofloxacin if they're penicillin allergic, or something like amoxicillin clavulanate if they're not penicillin allergic. They need to have that at home. And if they have a fever and they're more than 2 hours away from being able to be evaluated, then they need to take it while they're seeking care. If they can be evaluated within 2 hours, then you see them in the office. They don't need to take their antibiotic. So in the last just couple minutes, I'm going to talk about transplantation, and I want to start with a case. This is a 39-year-old woman who had a kidney transplant 7 years ago, who presents with 3 days of diarrhea and a fever. She generally feels unwell and is having frequent diarrhea, but no other symptoms. Her medical history is notable for IgA nephropathy and the kidney transplant. She's never had CMV infection, and she's never had rejection, so she's done quite well, and you can see her meds there. Her social history, she's an accountant, she's married and lives with her son and spouse, and she has a pet, the 7-year-old son has a pet hedgehog. We ID doctors like our home info, and she likes to garden, so she's outside a lot. When you see her, she's tachycardic and febrile. She has diffuse tenderness in her abdomen without rebound or guarding. So the most likely cause of her illness is A, salmonella, B, CMV colitis, C, norovirus, or D, mycophenolate toxicity. So go ahead and ring in. Think carefully about this one. Notice I didn't put COVID-19. I'm sure she would have been ruled out if she showed up right now because she has a fever. But the answer is not COVID-19. Okay, gonna give people just a little bit more time. All right. And I'm gonna cut your voting off. Now, it looks like most people like CMV colitis and then equally norovirus and salmonella. This is one of my favorite questions, although when we did the automated voting, I didn't get cryptosporidium in there. It's one of my favorite questions because everybody wants to answer CMV, and I will explain to you why on the next slide, why it's not CMV. But you'll notice if we've gotten all the questions in the ARS, CMV colitis and cryptosporidium are opportunistic infections. Norovirus is something you can get in the community, but it doesn't quite look like this, right? Like people don't have high fevers and belly pain with norovirus, so that's why that one's not right. And then mycophenolate, she's been on for a long time. So my next slide is really my only transplant slide, and it's going to answer why I said this. So what you really need to know about transplant patients is when their transplant was and if they've had rejection. In her case, it was 7 years ago, so we'll get to it in a minute. If it was 1 month ago and she was showing up, then we'd say, well, this is most likely nosocomial. It's probably going to be related to the hospitalization for transplantation. So it would be something like C. diff in this case, or these patients can get catheter-related UTIs. They can also get wound infections at the site of their transplant. And then when patients are 1 to 6 months out from transplant, that's when you see the opportunists. That's when they get CMV if they're not on prophylaxis, because that's when their immunosuppression is high. Also, if somebody's been treated for rejection, they fall into this category. And then when people are more than 6 months out from transplant, that's when they get stuff from the community. This is when they show up with their norovirus or with their strep pneumo, with their COVID-19, because she lives out in the community, right? She lives with a hedgehog. And it turns out that hedgehogs can transmit salmonella. So if you knew that about a hedgehog, you might have figured out my question. So anyway, that is the reason that this is the answer here, because she's really out in the community. She's at risk for things at home and in the community. So in summary, the immunocompromised host with infection presents with attenuated signs and symptoms of infection. When you're treating them, you need to consider the net state of immunosuppression and their epidemiologic exposures. Asplenia increases your risk for overwhelming infection, so you need to vaccinate and educate. And transplant recipients are susceptible to a very wide range of infections, but their risk depends upon when the transplant occurred and if they've had rejection. And with that, I'll thank you for your attention, and I hopefully I maybe have just a couple minutes for questions.
Great. Terrific, Sarah. Thank you very, very much. And I don't know, can you see the questions, or I'll read some to you?
Yeah, read some.
I'll read some to you. Okay, here we go. So what dose and duration of steroids related with reactivation of hepatitis B or other viruses?
That's a great question. So the American Gastroenterologic Association has a nice set of guidelines on hepatitis B reactivation, and they break it down into the steroid dose. And I think for people who are surface antigen positive, they can't tolerate a lot of steroids for very long before you worry about reactivation. So I think it's really like a week of high dose, meaning like more than 20 or 30 milligrams of prednisone per day, and you should be worried. Whereas core antibody positive people who are surface antigen negative, you can give them a lot of steroids before you have to worry about that.
Great. Next one is for someone who doesn't have a spleen, do you have to vaccinate with Bexsero? That's the B meningococcal vaccine, in addition to the conjugate meningococcal vaccine, Menactra.
Yes, that is the answer. Yes, I that was what I was just talking about. You don't necessarily have to pick Bexsero. I think there's another brand. You need to vaccinate them for meningococcus type B and with the conjugate AC, W, and Y.
Good. Here's another one for people without a spleen. If they've been vaccinated with the conjugate pneumococcal vaccine, the Prevnar, as a child, after they lose their spleen, do you need to revaccinate them with the conjugate vaccine?
That is a good question. I think, what I'm excited to say is that our next speaker is going to talk about vaccines. But I think you can look at the CDC. They have amazing tables, which I know our next speaker is going to highlight, where you can look it up. But as in my practice, I believe we have been doing that because typically the time since they were vaccinated was very far. I will say, I don't practice in adolescent medicine, so I'm typically seeing somebody where it would have been many years since they were vaccinated. But I think our practice is to sort of follow the baseline adult CDC guidelines, which would recommend that you would do your conjugate and your polysaccharide.
Terrific. And I think we have time for one more. Any special consideration for patients who are BCG vaccinated who are going to get TNF alpha inhibitors? These are tough questions.
Yeah, that's a good one. So, it turns out, and I know that we have a lecture on tuberculosis, that might be somebody where you would want to check a T-spot because you can build their confidence by telling them that a T-spot should not be falsely positive because of the BCG vaccine. So it's a way that you can look and sort of get the confidence of the patient and say, well, this test will not be falsely positive. So if it's positive, that really means that you need to be treated for latent tuberculosis. Because there are, some areas of the world where people get BCG where TB is actually not such a huge problem anymore. For example, I believe Portugal maybe still vaccinates people, or did at least recently, where, plausibly somebody could not have been exposed but might have gotten the vaccine.
Great. Well, thank you very, very much.